multiple pulmonology journals. Dr. Strange himself is very well published in alpha-1 antitrypsin deficiency, interstitial lung diseases, and COPD, having authored or co-authored over 200 papers and book chapters. He directs the Alpha-1 Foundation Research Registry. He's currently conducting several clinical trials revolving around alpha-1 antitrypsin deficiency. Dr. Strange has been consistently named one of the best doctors in America in interstitial lung diseases and COPD for 13 years straight now. And please join me in a round of applause as we welcome Dr. Charlie Strange.
Well, thanks so much. What a kind introduction. So I left Charleston this morning on the direct flight down, so I get to see the hurricane twice when I go back this afternoon. But it is my honor to be here, and thank you so much for the invitation. What we're going to do today is we're going to talk about COPD as a big disease state. It's obviously got lots of different facets, but it'll be a kind of a potpourri talk about all the new things happening, some of which have implications across the whole field of internal medicine. And at a medical grand rounds, it's not all about pulmonary disease, because this disease crosses all disciplines in medicine, and I hope to show you that over the course of the next 45 minutes and leave some time for questions. In the old days, we used to define this by phenotypes. That is, people have cough and mucus that happens in 3 months of each of 2 successive years, chronic bronchitis, or they had holes in their lungs, emphysema, and this is what we called COPD. But about 15 years ago, the disease changed. It's one of our disease states that is defined by a test, the test being spirometry. And in the same way you wouldn't make a diagnosis of diabetes without a glucose or an A1C, we don't make a diagnosis of COPD without a spirometry that shows obstruction. And so this definition has kind of stood the test of time, and then we start getting these arguments. Well, what if somebody has asthma or other obstructive lung disease for 25 years and shows up and now they have some obstruction? Do they have COPD? And so our pulmonary groups start arguing back and forth, which has led to our guidelines to recognize a new syndrome that we're going to talk about in just a minute. COPD, number 3 killer in America, behind heart disease, number 1 for men and women, cancer, number 2 for men and women, and COPD being number 3. It's number 4 worldwide, number 3 in the United States, number 2 calls for disability in America. And so when we start looking at how many research dollars, what we know about COPD compared to cancer and heart disease, we have about 1/10 the funding for a disease that really impacts us all, whether you make the diagnosis or not. This is the map that the CDC puts out for county-by-county prevalence of COPD. And I was looking down here at Miami. Y'all look pretty good, but remember that COPD is a disease of old people. And Miami, with its influx of the young and rich and famous, must have lower instances of COPD, or else it's just not being counted well. But regardless, you see that this is a disease of the southeast corridor. The high prevalences through Appalachia really just reflect the high smoking rates. One of the things that most of us don't really recognize well enough is that this is a disease of aging. It's a disease of the aging lung, much the same way many of our other internal medicine diseases are associated with aging. And this data came out of the NHANES registry, where a researcher from the CDC went and knocked on people's door and asked them if they had COPD or not, and then pulled out that magic machine called a spirometer. They then did the spirometry in the home to figure out who had obstruction and who didn't by age ranges. And so when we start looking at those diagnosed with COPD in the bright green, and then what happens over the course of time at age greater than 75, having 23% of the U.S. population with COPD, we realize that when you go through all your geriatric clinics, I guarantee you there's not a COPD diagnosis on 1/3 of your charts there. And at the same time, to recognize how important spirometry is, to recognize that advancement of age and how it impacts lung function. And what we do about it is the second part of this agenda. Our new syndrome, arguing about this group that have asthma overlap, it's called the Asthma COPD overlap syndrome, that was recently put into our COPD guidelines about 2 years ago. The GOLD guidelines, we'll talk about it a little bit later. But I wanted to share with you this dichotomy that happens between asthma disease, where if you have asthma in the Mayo Clinic database, you don't have any higher death rate than people that have no asthma in the large group of individuals, 5% of the U.S. population with asthma. However, our COPD, with the number 3 death rate in America, obviously something's different. And so what happens if you go see one doctor and they say you got asthma, and the other doctor over here says you have COPD? And we all know that some of our COPD individuals have a whole lot of bronchial hyperreactivity. If we do a test called the methacholine challenge that measures how bronchoreactive you are, 65% of individuals with COPD have a twitchy airway. And so this diagnosis is really kind of difficult. And if you think about all of our COPD trials, if you ever say you have asthma or some doctor has told you asthma, what happens in those trials? Where you get kicked out. So we've never studied this group of individuals with the asthma COPD dual diagnosis that we actually think happens pretty frequently. So as many of you know, the CDC has a guideline, has a survey that is done yearly throughout every state. Every state in the union has to do telephone calls to 10,000 individuals. This is called the Behavioral Risk Factor Surveillance System. And for the first time, we actually had a COPD module put in it in 2012. So the caseworker asked, have you been told by a doctor that you have COPD? And have you been told that you have asthma, and all the follow-up questions? And this dual diagnosis came out as 3.4% of the group that have COPD out of the whole population of 90,000, compared to 5.5% of those who some doctor had only told them that they had COPD. So the point is, this is a really big group of our patients that have COPD. So do they act more like asthma, or they act more like COPD? Well, these are the age distributions of the individuals that have ACOS on the left compared to COPD, and the prevalence rates actually increase just like COPD. And the other pieces of this are what kind of individuals. These are female predominant individuals. They tend to be overweight. They have a higher instance of never smoking, and one of our topics today that we're going to talk about is this 20 to 25% of never smokers that have COPD, and we think as smoking falls in the United States, that prevalence rate will actually continue to increase. Diagnosis by spirometry, 90% of individuals have had spirometry in this group. Health insurance, 90%, but 23% didn't see a doctor because they couldn't afford the copays. And so this whole concept of disparities and how much impact of the healthcare system is on our ACOS diagnosis or not is really a hot topic. What came out of the work around what other diseases these individuals have, we think that asthma is a disease that really doesn't impact other organs quite the same way COPD does. But we have known for about 5 years that if you have a diagnosis of COPD, then your incidence rate of our common comorbidities, myocardial infarction, stroke, depression, arthritis, is at least twice as high as those individuals that don't have COPD. The theory behind this is that COPD, an inflammatory state in your lungs, activates inflammation throughout the rest of the body that somehow contributes to other organ failures that are in dysfunction. And in this group of individuals that have ACOS compared to COPD, the comorbidities in the black bars are very much higher than those that have COPD alone, that in and of themselves are twice as high. So we think that this is a really important new diagnosis. It's going to have a whole lot of research coming out, and something that you should pay attention to with this new diagnosis of asthma COPD overlap over the next few years. Now, this is probably the most complicated slide that I'm going to present to you today, but what I'm going to show you here is this whole concept of how COPD influences the comorbidities that we all see in internal medicine practice. Let me talk you through just one of these. For instance, let's talk about diabetes. What we did here was take and overlay the presence of obesity on the COPD-associated prevalence for each of our common comorbidities. And so if at normal weight we have COPD, the chance that you have, I'm over here, chance that you have diabetes is an odds ratio of about 1.5. But now if you go from normal weight up to morbid obesity, the incidence rates for both COPD-associated and unassociated COPD go up, but they go up about the same. So we really don't think that there's a major difference here. But if you move over to myocardial infarctions without COPD, myocardial infarctions with COPD, stroke without COPD, stroke with COPD, you can see that there's this huge impact of BMI in the prevalence of these other disorders. And we already know that BMI impacts atherosclerosis and vascular disease, but when you overlay COPD, nobody really understands why that happens, but it's more than an additive effect. And another hot topic that y'all should follow through the course of the coming years. Okay, let's switch gears and talk a little bit about our diagnostic strategy here. And I think this is the slide from the GOLD guidelines that suggests that everybody with symptoms and or exposure should get a spirometry. We all know that spirometry is a hard test to do. If we go through the Medical University of South Carolina EPIC chart and look at how many people with a COPD diagnosis have actually had a spirometry, the number is about 30%. I'm sure it's that way in most places. And yet this whole challenge for us to teach spirometry to primary care, regardless of specialty, has really been hard. And I think it's been one of these things that we've struggled with for years and don't have all the answers about. What we're really looking for are the techniques of 6-second expiratory time, the forceful blast that starts from time 0 and doesn't waver, and getting 3 reproducible values that hit the same FEV1 within a 5% difference over time. We also have the difference in, if you have a low FEV1, is this a restrictive disorder, meaning that you have something that will not let your full forced vital capacity out, or not. And we have a lot of people giving albuterol for restrictive lung diseases, and just this next step of interpretation that falls on the physician community is also very hard. So there are a lot of issues around spirometry. We have recommendations to look at the ratio FEV1 FVC less than 0.7 as the diagnostic criteria to enter into a diagnosis of COPD, and then use the percent predicted FEV1, mild, moderate, severe, or very severe, as then your stratification of severity of disease. These are under siege in both our pulmonary community and from the primary care. We'd love to have a questionnaire that makes the diagnosis just as good as spirometry. It just isn't out there yet, and so spirometry is important. We've started doing spirometry on every patient in the hospital on the day before discharge to prove whether they actually have COPD or not. And many of them do not and have normal spirometry, and it was really their heart failure exacerbation that led to wheezing. And so this getting the right diagnosis thing is real important as well. One of the concepts that has been around since the 1970s is this Fletcher-Peto curve. And under this theory, we all start as small babies, and our lung function, whether it's FEV1 or FVC, increases over time. We then all reach age 25, and we're all over the hill. We start that normative decline with aging in our lung function. And if you smoke and are a susceptible smoker, that's estimated to be 15 to 20% of the population, then you'll take this course of accelerated decline and reach symptomatic lung disease at an FEV1 of 1.5 liters, oxygen need at 1.0, death at 0.5, and it's really pretty ugly. And some nice and elegant studies have shown that if you quit smoking as the cause of your COPD, you can return the course of your lung function decline parallel to that of the normal population. This was challenged recently in a New England Journal of Medicine article, but this concept everybody should be familiar with in the COPD literature. And these 3 large databases, Framingham, the Copen-City, and Lovelace cohorts, totaled about 30,000 individuals, and they looked to see how many people actually had a more rapid decline of FEV1 associated with their COPD on serial testing. And what happened there was that a fair number of individuals failed to achieve that peak that is in the normal range. And if you look at the individuals that ultimately were diagnosed with COPD, more than half of them actually had a failure to achieve their peak lung function and a curve that was parallel to that of the decline rates of this active population. What does this mean? Well, it means that pediatric causes of COPD account for about half of our ultimate diagnoses in adulthood. What this means for us, and we see it from our neonatal ICU survivors with neonatal lung injury, is that we really need to think about COPD as a lifelong disease and focus just as much on pediatric lung infections and developmental pieces of our lungs as we do on this rapid decline that does happen in COPD that we have been traditionally focused on. And so just a different way to think about COPD that now moves across all age spectrums and not just in our geriatric clinics. The other thing that's fun is that we know there are a lot of undiagnosed patients out there, and so this concept of who do you send for spirometry is a really tough one. So we actually used our state data in South Carolina in the BRFSS survey to look at this group that the doctor has told them they have COPD, but then compared them to those individuals who had smoked for more than 10 years, had shortness of breath most days, productive cough or productive coughs most days, or breathing problems increasingly affecting their physical activities. So we thought this was a fairly good surrogate for those individuals that probably should have had a spirometry if all things were equal, and it was a free test. This is done county by county in all states, including Florida. We have those areas of the state that have high risk for disease, our mountain areas, and this is a historically indigent area of the state down here. We can map out those, but the important part here was although 9% of the individuals in the state of South Carolina, of the 10,000 that were surveyed, the doctor had already told them they had COPD, there were another 8% that met one of those criteria for high risk, for a total of 17% of the population of our state that might have COPD. It might be as high in Miami, I don't know, but the point here is that it's the groups that have females more likely to have COPD, African Americans more likely to be in this underserved high-risk population. We can then overlay the household sales of tobacco, in which more than 7 packs of cigarettes were sold in a given week, and therefore you can kind of then figure out if this is smoking related or smoking unrelated COPD, and it gives our healthcare workers really good tools to be able to monitor COPD. And so this BRFS survey is going to be done in Florida this coming year with a COPD module. Only 9 states picked up the COPD module last time. You get to pay for your modules on each yearly survey. But it's a nice way to do epidemiology for all the diseases inside of internal medicine. And it's kind of fun stuff. It helps our state healthcare tobacco monies flow in the right direction. I thought I'd switch gears and talk about emphysema a little bit. Emphysema, as we all know, is airspace enlargement without surrounding fibrosis. We don't like to take the idiopathic pulmonary fibrosis patients that have scar in their lung and have a honeycomb change and say that hole is emphysema. Emphysema is best seen on a CT scan, and you know how many CT scans get done through the emergency room here. It's one of these things that they'll describe in detail, the 3-millimeter nodule and all the other pieces of that. What I'm going to encourage you to do is actually look at your CT scans as they come up to the floor with a reported pneumonia or some other things, and look at them for these low-density areas that might have emphysema. We found our radiology group, although they're good at what they do, will often miss emphysema, and to know if people have emphysema or not is one of the tenets of COPD, is an important thing. And if you start looking at your COPD patients with a little bit more interest, you can see some other things on CT scans occasionally, and it might help in their health care to note that the pack of cigarettes was still in the pocket as they put this guy on the table. So don't be afraid to look at your CTs. We have a lot of questions around our causes of COPD that are not related to smoking. We don't have very much data at all on e-cigarettes, marijuana. These are obviously hot topics for the future. It's been very hard to show that secondhand smoke is associated with COPD, although it is with childhood respiratory infections. We also have these rare causes, and so in my clinic last week, we had a lady who had urticaria and just couldn't breathe well and ended up having hypocomplimentemic urticarial vasculitis as the cause of her progressive emphysema. HIV is on this list. Some rare diseases like Ehlers-Danlos and Marfan's are on the list. Cutis laxa, disease of elastin degradation, which your skin gets floppy, causes elastin degradation in the lung. Very rare disease. The disease that is also on here that I spend a lot of my time with, and you have excellent support here at the university with Dr. Campos and Dr. Warner, is alpha-1 antitrypsin deficiency. And I can't go to any COPD grand rounds without talking a little bit about alpha-1. Alpha-1, as y'all know, is a disease of genetic origin, and there's a single base pair mutation on chromosome 14 that gives this poor folding of the alpha-1 protein. The protein doesn't fold, therefore it can't get out of the hepatocyte, and we get a liver disease associated with the globules inside of the liver. And then because the serum levels are low, we can't protect our lungs against injurious agents, particularly cigarette smoke, and get this classically lower lobe predominant emphysema. We know that one of the hardest parts about here is figuring out who to test, and we have guidelines that say every individual with COPD should be tested. But if you're only making a diagnosis of a third or half of your individuals that have COPD, we're leaving a lot of people on the table. This is a sibling pair study where we had a bunch of known alpha-1 patients. Typically, they have low lung function at an early age, but we asked their brothers and sisters that also had ZZ genotypes to come into the clinic and do lung function and confirm their diagnosis. And so here's this smoker at age 65 with 100% lung function up here, and you see that even though there is this risk stratification around smokers getting more severe disease, this heterogeneity is really huge. We're trying to understand this in ways that we really don't know right now. So just recognize if it's only young ages that you're testing for alpha-1, if it's only cigarette smokers or not cigarette smokers that you're testing, there's really no good reason to be doing that. The reason I think alpha-1 is an important study for all of our genetic diseases is all about the family. This is one of my families. This individual is actually a lung transplant recipient that I see in my clinic, who just happened to have 4 brothers and sisters. 3 of the 4 were ZZ individuals, and one of them just happened to marry another individual that was a carrier for another Z allele, and ended up having 3 of 3 kids that are ZZ. And so when you test, you're not just testing this individual, you're testing a family, and this whole process to test a family is important for all the things that we do in medicine. At MUSC, we have a website where we actually allow home genetic testing for family members of alpha-1, so we get a fair number of Florida detection kits run through that program. We run a registry for the individuals that are affected so we can advance research, and have, to back up our genetic testing program, a genetic counselor that works in our alpha-1 space that any of y'all are welcome to use. It's a telephone number advertised widely on the web for alpha-1 genetic counseling that you can call up and talk to Kim, who has chats all day long across America about how and who to test and what the test results mean. And all of this would not be quite as important if we didn't have research and medicines to treat alpha-1. And so this is a 2015 publication in The Lancet showing that our alpha-1 augmentation changed the rate of lung density decline from the control placebo population to those getting medicine. And then at 2 years, when medicine was given to all individuals, actually changed the slope of lung density decline, our strongest measure of emphysema for the subsequent 2 years. So I think everybody in the world is pretty convinced, at least in the United States, that alpha-1 augmentation therapy slows progression of emphysema. One thing that we are still struggling with is that despite therapy, we're still having COPD and emphysema progression that we don't fully understand, and really can't cut off this ongoing lung loss that's associated with the aging process. We're going to spend the rest of our time talking about therapy. Our guidelines here are put out by the World Health Organization, who convenes a panel every 6 months to make recommendations on guideline changes. The gold panel is subscribed to by all of our professional organizations, the American Thoracic Society, the American College of Chest Physicians, and so they're on the web and available for your perusal really at any time. I personally don't like them very much, so I made my own guidelines because I kind of like some of these that give you, let's do step 1, 2, 3, and 4 better, but all of these are encompassed in the gold guidelines. But number 1, obviously, is smoking cessation if you're a smoker. Bronchodilator therapy, number 2. Exacerbation prevention, we'll talk about in the next few minutes. Targeted therapy of exacerbations. We're not going to spend a whole lot of time talking about pulmonary rehab except to mention that. Influenza pneumococcal vaccination, some controversies coming around oxygen. And then I did want to spend some time treating hyperinflation here with some of our new devices. First, smoking cessation. We're proud in South Carolina to be one of 7 states in the union to get straight Fs on our American Lung Association report card for all of our smoking initiation. I was pulled up Florida, and you get a B for your smoke-free air initiatives. You did that at a statewide level, whereas ours are at community level, so we get an F. And you got a D on the cessation coverage of your medicines, but we get straight Fs, and so studying COPD in South Carolina is not such a bad thing to do, right? I did pull up the Florida numbers, though, so that your state spends $67 million a year on smoking cessation initiatives. At first glance, you think, well, that's a lot of money. Your federal funding, a lot of it coming here, and the University of Florida, another $2 million. Your CDC best practices suggest you should be spending $194 million. And so you're doing 36% of what the CDC says, but the CDC is just a federal agent. We all need to slash the federal budget, right? So you put all that political stuff into this, but you recognize that the state tobacco-related revenue is $1.6 billion coming in just to the state of Florida, and now the argument twists a little bit. So shouldn't we be spending at least 1/10 of the state revenues on tobacco in trying to help tobacco cessation be better? And so the American Lung Association has done this for about 10 years. They'll track your states on along. They call people out. They count the money accurately. I trust their numbers. And so those of you who are politically active now have something you can do in your own state. Our gold guidelines are a little bit complicated, and they've gone into this ABCD system. And it used to be pretty easy. We had spirometry that was really bad, gold 4, or really good, minor obstruction, and we said spirometry gets worse as you head up, therefore COPD is worse. And the problem with that system was that we have some people with relatively good spirometry that are in the emergency room, and they're in the hospital, and they're there with exacerbations out of proportion to the degree of their spirometric obstruction. And why that happens, most of it's a chronic bronchitis and or asthma COPD overlap syndrome patient that's doing that. And so the Gold Committee said, well, spirometry alone is not enough to characterize this disease. We really have to understand the exacerbation and hospitalization rate in a very different way. And whether you count as exacerbation frequency per year in your clinic charts or a hospitalization that seems to be a seminal event in the life of many COPD patients that leads to further hospitalizations. This concept is different. And then we put on the x-axis a symptom score, either a dyspnea score or this COPD assessment test score, have both been used and are both suggested and approved by the Gold Committee. And on top of the ABCD criteria, they will then recommend medicines that should be associated with that. The D's obviously are the worst, means you can use triple therapy of LAMAs and ICSs, and we'll just talk about the medicines here in just a minute. But this is a little bit much to memorize, and I think the concept, though, is clear that it's not all about FEV1. Exacerbations matter. The more exacerbations, the more medications that we actually turn on. Those of you that follow the FDA recognize we've had 14 new COPD medicines in the past year. So it's one of these overloads in clinic. All of them might not end up on the formulary at your hospitals here, but to have different medications. These are our medications that are beta agonists. These are our medications that are anticholinergics. We have umeclidinium, glycopyrrolate, olodaterol and decaterol as medicines that are new and available as single agents in formulary. What happens on all of these is that we can reduce the maintenance exacerbation frequency by either a long-acting muscarinic antagonist, a long-acting beta agonist, a combination of a LABA and a LAMA, or a LABA and an inhaled steroid. Notice that not all of these regimens include an inhaled steroid, and so when we talk to my house staff and faculty, overwhelmingly people have historically used LABA and inhaled steroid as their exacerbation reduction medication, but we now have pretty good evidence that all of these combinations reduce exacerbation frequency. Our new kids on the block are these LAMA-LABA combinations, and we now have 4 of them that are FDA approved. They have very few randomized trials between the different ones, so we really don't choose between them very much. And we also now have 4 inhaled steroids and LABAs. And I'll show you the one trial that did come out in the New England Journal just this year that compared a LAMA-LABA to a Alaba ICS, looking at outcomes and exacerbation frequency. And interestingly enough, the LABA-LAMA, as most of us thought, won this battle. And what that tells all of us is that we have lots of options these days for exacerbation reduction, and this new bronchodilation without an inhaled steroid and its side effects of pneumonia is a viable option. We need more studies, but this one was well powered to do these exacerbation studies. Needs about 3,000 to 5,000 patients followed for at least a year. They're very large studies to do. They cost a lot of money. Therefore, the downside of the LABA-LAMA is a more expensive product at the FDA. And so we just recognize that expense doesn't always follow exactly, but it did in this case. The other large study that published out last year was Summit. The concept was if you were to go and make a diagnosis of COPD in all of your 82-year-old people in geriatric clinic, Dr. Denise, should we treat every single one of them with a very advanced and aggressive medication to reduce mortality or not? And so this was a mortality time to event trial for 1,000 events, comparing 4 arms of an inhaled steroid and LABA regimen. And there was for the combination of fluticasone and vilanterol, the LABA-LABA, 12.2% decrease, p-value 0.14, and secondary endpoint times to first exacerbation decreased by 20%. And this one met statistical significance, but was not one of these overwhelming, we're saving tons of lives, and I don't think this study is going to be repeated again, just because to be able to do this study was about a $400 million study by one of the pharmaceutical companies to actually try and figure out if treatment of every COPD patient needs to be done by guideline care for a mortality endpoint. We know that quality of life is better if you're adequately bronchodilated and treated, but this controversy of going after mortality reductions the same way the cardiologists do with all of their trials isn't going to happen in COPD. So it's about quality of life, and yet we get the trends towards less exacerbation, more exacerbation reduction, and that leads to dollars saved at the hospital level. I'm going to talk for a second about oxygen, and one of the concepts is that we've given oxygen to a lot of patients throughout the years. If on an oximetry or a blood gas you plummet your oxygen when you exercise. One of the controversies there is that we've never actually had a randomized controlled trial of oxygen for people that have moderate degrees of oxygen desaturation with exercise or with sleep, and then with oxygen prove that patients do better in the long term. And so imminent any day is the publication of the LOT trial, the long-term oxygen therapy trial. Took a group of individuals that did just that, had resting oxygen saturations greater than 92%, but with exercise went lower than 88%, and asked them, are you willing to be randomized into 5 years of oxygen or not? And they had to then ask their doctors whether the doctor was willing to randomize them into randomization of oxygen or not. And as a result, 7% of individuals eligible for this trial actually enrolled. They paid the electric bill of every patient in the study because electricity is needed to run your oxygen concentrator. And the study was not stopped over 5 years by the Data Safety Monitoring Board, leading us to suggest that there may be no difference if you desaturate your oxygen and stop and rest and let your oxygen come back up, then you might not have a mortality or cardiovascular endpoint, which was the reason behind this large trial. So pay attention. I don't know the results of this, but I've been waiting for it for a while, and word has it it's at a prominent journal and ready to be published. I was hoping to have the results for today, but they didn't come out. I'm sure there are multiple pulmonary rehab programs in Miami. For us, the one thing when I see COPD patients in my clinic is the one thing that's underdone by the rest of the world. When I can take someone and throw them into a pulmonary rehab program that Medicare gives us 36 sessions for, 3 times a week for 12 weeks, and my respiratory terrorists take the patient, they throw them on a treadmill, and they pull out their whips, and they get them going. We're taking grandma, we're making her work, and we're doing it in a supervised manner. We're making sure she's not having heart arrhythmias and myocardial infarction on the treadmill. But what it transitions their muscles into being very much more able to utilize the oxygen presented to them and produce less carbon dioxide. The reason that people have dyspnea with exercise is that they breathe fast. And if you produce less carbon dioxide at your muscles, then you would then have to breathe less, and so you can walk now 2 aisles of Walmart instead of 1 aisle. You have actually transitioned quality of life by getting your muscles working rather than anything else. And so Medicare is seeing this data. Everybody gets a once-in-a-lifetime benefit of 36 sessions. For lung transplants and special situations, we throw people back into pulmonary rehab. But it's an underutilized service. It makes a huge difference. Everybody has the medicines down for bad COPD, but pulmonary rehab that then is sustained after the 36 sessions is a really level evidence A intervention that really works. There's a lot of work about stem cells these days in COPD. I have a little bit of a interesting bias here. I love in Miami y'all's Ageless Regenerative Institute, who does adipose stem cell collection. I don't mean to offend anybody if you're here, but I think the PI, being a plastic surgeon, probably says that this was probably not one of these studies that is really designed at understanding the deep science of how stem cells might work for COPD. But the studies that have been done that really have not led to publications with benefit. But we get this question all the time because of all the advertisement. And there is a statement from the COPD Foundation and the Alpha 1 Foundation about stem cells for COPD. And we really just don't have information, although there are some centers, Little Rock and Moscow, that are actually doing good pulmonary studies with stem cells. Our last topic before we take questions is about hyperinflation. And hyperinflation we all see on chest CT scans, particularly with emphysema. And this is when you start climbing the flight of stairs with your emphysema and you start breathing faster, and the lungs fill but don't completely empty because of the small airways and air trapping that occurs. So at the top of the stairs, you get dyspneic and your lungs get bigger. They get bigger with each step, with every inspiration that's not fully expelled. And what happens next is that you get a tight chest. And you come in to the doctor and you say, "Doctor, I climbed a flight of stairs and I got a chest tightness." And what do y'all do? Yeah, you send them to the cardiologist. They get a stress test. Some of them say, "Oh, the stress tests aren't very good. We need to do the cardiac cath." And then they say, "Oh, it's not your heart. And let's go see the lung guys." So just recognize that this is a very prominent part of the hyperinflation of COPD. And we have pretty good evidence that hyperinflation is associated with bad outcomes in COPD. We can treat this. One of our 2 interventions that are mortality endpointed in COPD is the surgical lung volume reduction. This was done by a series of centers, the closest one to anywhere in the southeast was in Duke, and the original 17 centers that were done in the NIH study have stayed centers, and no new centers have emerged. Is anything done here in Miami with lung volume reduction surgery? No. So the point is people have to travel a long ways. The theory here is that you're shrinking these hyperinflated lungs by taking off particularly the parts of emphysema that are the worst, that tend to be at the upper lung zones. And you throw a third of the lung with staples into the trash can. Now your lungs are smaller and quality of life is better. There's only a 5% perioperative mortality. So when you're talking to Ms. Jones, it's like, Ms. Jones, they'll take you next Monday. It's only a 1 in 20 chance of dying. But if you survive, do you want to live longer and do better? What does Ms. Jones say? I don't know. We didn't do but about 50 of these in the United States last year. Most people say no. And one of the reasons they're saying no is that we think we can do this with the bronchoscope. And there are now 4 therapies in the mix, some of them going to FDA panel here in the next year. And 2 of these flow regulate airways disease with endobronchial valves. These are valves that have a one-way feature of them. And if all your emphysema is in your upper lobe, and you can valve those airways so now all the ventilation occurs to the other parts of your lungs, then that lobe should collapse. And now the other good lungs and heterogeneous emphysema of different severities would then be able to take the place. These have been the subject of New England Journal of Medicine trials. There's a current study with Dr. Campos at the VA hospital using the spiration valve. And the point is that these look like they really work, but you have to heavily phenotype your patients to make sure that there's no collateral ventilation across the individual lobes in the lung. I'm going to show you the endobronchial coil next. It is not FDA approved, and I was a researcher here, and so put my disclosures out there. And the fourth one that is not dependent upon fissure integrity and actually compresses tissue is steam that's applied to the areas of worst emphysema to be able to make the lung coagulate and be able to heal with a scar there. And that has a positive phase 2 trial out of Europe. The coil is made of nitinol. Nitinol is the metal that doesn't rust. It's what they use for heart stents and other vascular stents. The procedure is done into the area of worst emphysema. This is a flexible bronchoscope that in this case done in France was done through a rigid bronchoscope. The stylet goes out. The next thing that happens is that a sheath is passed out over the stylet, and the sheath is left out to the periphery of the lung. The coil is then straightened and injected out through this coil. It comes out through the sheath, and then we'll pull the sheath back and leave the coil to then target the lung. And what happens is that it grabs distal lung tissue and is then able to pull that distal lung tissue in. So you're actually adding elastance to this lobe that was big and floppy that had emphysema. So we go through the lung and try and put coils in different lung segments so that you end up having a chest x-ray that looks kind of funny at the end of this procedure. And so this is a coiled patient that then you should not do a thoracic surgery on this patient. The staple lines will not seal across these coils. The randomized controlled trial of, we did this sequentially bilaterally, just came out in JAMA. It was looking at 6-minute walk distance that wasn't perfect, but the trends were higher responder rates in the individuals getting coils than the ones getting placebos that had higher rates of decline. And similar sorts of a St. George's Respiratory Questionnaire fell on average more than 4 points and is closer to 8 in the responders compared to the control population. So this met all of its statistical endpoints. It's going to the FDA. We'll see if coils are released to America, and then trying to figure out how many patients with emphysema would get this therapy becomes the next topic of discussion. The big deal going on these days at my medical center is all about COPD readmissions, patient-centered care, trying to get every patient to a patient home. We realize that COPD involves not only the pulmonary guys, but pulmonary rehabilitation specialists. It crosses through hospital all the way out to LTACs and emergency departments as well. One of the things that we have come to know pretty well is that patients aren't very compliant with their COPD medicines. This is one of my favorite studies that was done about a decade ago, in which unbeknownst to the patients, there was a counter in the puffers. And it was a 5-year study of bronchodilation on FEV1 decline called Lung Health 1. And they were supposed to take this. And this was the group of patients, 12% of them, that had more than 100 actuations of their puffers in the 3 hours before they came to the clinic, just because they're getting ready to see the doctors in the research area. And so they realized that they just wanted to have an empty canister at the time that they showed up, so that they could try and help the doctor understand that they are compliant and want to be compliant with their care. And so I think it's just a point to be made. It's a fun study just to recognize that compliance is important. And on these exacerbation frequencies that are reduced, it's hard to know if you don't feel better with a bronchodilator, should you take it longitudinally every day for a year for exacerbation reduction? And the answer is yes, if they've been frequent exacerbators before. MUSC, in their last 6 months, this is the publicly reported data, had 168 COPD discharges, 34 or 20% readmissions rates. That means we are right on national average at 0.99% of our distribution curve. But this whole deal around readmissions, like we paid for back in the hospital, has been a target for a lot of COPD care. And we've started using a fun app that we hand to the patients on an iPad that they have to bring back. They have 7 screens they have to pop through every day before noon. And if they don't get the 7th screen popped by noontime, they get a call from the call center to say, "What's going on, Mr. Jones?" And so there is and they do this over and over, so at about a rate of 98%, they have complete data on filling out this app that will then measure screening spikes. Symptom spikes that happen in patients happen to a level that activates the call center in 20% of patients every day. And what that means is that if you're going to be managing all of our chronic diseases, heart failure, diabetes, COPD, you have to have built in a management system that will change the way we practice medicine. It's not good enough to come to the clinic in a month, 3 months, or whatever. These are everyday symptom spikes that go to a nurse call team. They have an algorithm that's followed based on guidelines. There's a nurse practitioner that gets the phone calls of the patients that need to be seen. The whole downstream effect has been really quite successful. And so this is the way COPD is going, and this particular app was developed up at Temple. It's called COPD Copilot. And if you start looking at the impact on the interventions, there are a lot more medicines prescribed, a lot more clinic visits, a dramatic decrease in severe exacerbations that head to the hospital. And so these impacts are very real, they're very palpable, but it's the way COPD is going. And by the way, you get all this data on your COPD patients and the questionnaires that follow that let us lead all the young doctors here into a different COPD treatment of tomorrow. So we think this stuff is pretty exciting. So I stopped 10 minutes early so we could have a chat. Our conclusions are that the COPD world has lots of new options. We're real excited about the future. We've got a bunch of new inhalers. My choice of a new inhaler for a new COPD patient is a Alaba LAMA combination, provided they have insurance and can afford the co-pays of that. Large unmet need in compliance with medicines we think is helped by medicines that are more convenient once a day and therefore are likely to be taken. And there's obviously a much more integrated focus, focus on integrated care for COPD. Thank you for having me.
That's great. Thank you, Dr. Strange. So as we're thinking of questions, maybe I'll start with one. What would be the one factor, if you could just use one, that would alert you as the primary care physician to place a patient in a high-risk need to come back more frequently, like say every 2 months, rather than every 4 to 6 months. What would be that characteristic?
So the biggest predictor of who ends up costing the hospital money, which is what this man cares about, didn't mean to say that in a bad way, is an exacerbation. And the best predictor of a current exacerbation is a past exacerbation. We've struggled to figure out, we love to have a biomarker, we love to have something else that would predict exacerbation frequency, but our strongest evaluation is a past exacerbation. Some of those happen in the clinic. The severe ones are ER and hospitalized patients, and so those are the markers where we have to see our COPD exacerbations within 1 week of hospital discharge. They have to be seen again within 1 month to prevent our COPD readmissions piece. And I think that's at least one key that's been very successful for us.
Adam?
John, I have a question about the comorbidities and the odds ratios that you show for cardiovascular disease, etc., etc. How about going in the other direction? If you're a cardiologist, COPD is a comorbidity. Shouldn't be the odds ratio the same in both directions?
It should be the same, and yet if you're talking about a different group of individuals, so this is taking the COPD patient population, comparing them to the non-COPD, but you're right that those individuals that do not have COPD have, we didn't put the COPD triangle in there, but it can be turned around. But the concept is the same, that if you have sleep apnea, if you have coronary artery disease, if compared to your non-disease affected cohorts, your likelihood of having COPD is about twofold higher when you turn that question around. So it's an opportunity. All of us like to stay in our little silos a little bit. And what this has done is turn my COPD clinic into saying, yeah, did you get your A1C measured last time with your diabetes? Did, it's these chronic diseases flow together, and it's that integrated clinic that's so hard to do, but it's what we're all about as internists.
I'm actually very interested in that app that you mentioned, but on a practice, and it sounds like it would be cost effective. So two questions. One is, has cost effectiveness studies been done using the app in terms of reducing, obviously you said it reduces exacerbations, but reducing overall costs, because there is a cost associated with
Yes.
running it. And more practically too, how were you able to get, or where did you get funding to have the nursing in place and the call center in place and all these things?
Yeah. Dr. Jerry Kreiner is the chair of pulmonary medicine up at Temple, and he was the one that designed this and tested it in the Temple system. He has outsourced that to now a private company, and he proved in his cohort cost effectiveness, and yet the true costs are kind of being developed by this company. And so he has asked for 2 beta test sites. So I said, sure, I want to try this. And so we're testing it, and University of Alabama, Birmingham are both the 2 pilot test sites. We're going at this. We have our respiratory therapy readmission reduction program going. Whether it, in addition to that, is cost effective or not depends on, they're giving it to us for free, so you know what the pricing models of this, and apps aren't that hard to develop, so why couldn't you do your own? I think that's right. And our hospital as well is building these nurse call centers for all sorts of things, heart failure, COPD being one of them.
Marilyn?
So Charlie, so the theme of the comorbidities is going throughout pulmonary, right? And it's hit the fibrosis world very well. The other thing is also that's hit is the concept of chronic fibrosis with emphysema. Can you comment on this study for us and start how it differs clinically for the house staff?
Yeah, so when we smoke cigarettes, there are about 7 interstitial lung diseases that are cigarette smoke associated. And if you smoke cigarettes and you don't have any symptoms, you get hit by a car and they do an autopsy on you, about half of individuals have an inflammatory disorder of the small airways called respiratory bronchiolitis. Most of the highest prevalence of any smoking-related interstitial lung disease is a respiratory bronchiolitis-associated interstitial lung disease that progresses out into the lung a little bit from just being inside the bronchiole. And so I actually think these are very common. How often they present with clinical symptoms depends a little bit on whether COPD or this abnormal CT scan is really driving symptomatology. The answer for both of these is smoking cessation, so that message is clear. But the restrictive spirometry versus obstructive, and sometimes we have mixed disorders and need lung volumes and diffusion to sort out these, is one of the reasons that, at least in our Alpha 1 world, our new guidelines came out to suggest that a chest CT really tells us a whole lot, and yet we don't have studies in COPD where we do a chest CT in everybody with COPD. We have not done that study yet. I think it needs to be done because we'll find bronchiectasis and some interstitial lung disease and some things that we treat differently. Almost everybody at a big major medical center has had a CT for something. My plea is to pull it up and look at it when you're treating your COPD patients.
So right now in COPD, the removal of the inhaled corticosteroid is a very hot topic, wisdom trials and whatnot. I was wondering, in your case, what do you suggest? How do you treat or don't treat your COPD patients with inhaled corticosteroid?
Yeah, so the whole controversy of the inhaled steroids is right here, and this is really the first trial that has, there have been two studies. There's one other that took away the inhaled steroid, left the LABA, and statistically did not show a difference, although the trends were that the inhaled steroid was actually adding a fair amount in lung function to the LABA-LAMA combination being better than the LABA alone. So I don't know where all this is going to sort out. I think the message is clear, though, that a LABA-LAMA is a pretty good alternative, that although expensive at the current standard, we still, within the next year, are probably going to have our first generic monotherapies. So tiotropium is supposed to be out generic next year, and that's going to change the landscape because all these inhalers are very expensive right now. The withdrawal of inhaled steroid, particularly if people have pneumonia, thrush, dysphonia, osteoporosis, is kind of a no-brainer because we have good alternatives now.
Dr. Strange, thank you for a wonderful grand rounds. We wish you safe journey back home.
Thank you, Roy.
Can I just have everyone's attention for a second? There are a lot, this is typically Miami, where there's a lot of pandemonium about the hurricane. You'll get a lot of false emails and some mixed in with some real emails. Pay attention to the ones that come from the office of the CEO or the COO. The other emails are not necessarily authentic. So, and if you have any questions, discuss them with your division chief. Right.